So I want to skip ahead and then we'll come back because you brought up something that we're going to be talking about that I think is important to bring up, which is oligometastatic disease. So typically we see oligometastatic disease in the liver. You can also see it in the lungs, but most commonly we usually see it in the liver. So I'm curious what you all are doing in that case. So you kind of touched on it, but there's a couple of things out there that have been established in Europe that aren't used as much in this country. So curious, what do you do when you have an oligometastatic lesion that happens while the patient's on treatment? What's your next step?
Yeah, I think to me there, the liver is such a complex space. There's so many teams involved. So I think multidisciplinary approach there is so critical. Make sure your surgeons are involved. Make sure you had an MRI of the liver, especially. That's an area I've seen many times where we've picked up additional lesions, better characterized anatomy with MR versus CT. But also, I think, making sure everyone's at the table. If someone's upfront resectable, certainly, that's going to be your best approach by far. But using, your other tools, using Y90, using SBRT, ablations, et cetera, we've been able to convert many people that were not resectable up front to be resectable down the road. And then also, transplant, we have to talk about that now. We've been a center, we've done liver transplants for metastatic colorectal cancer for many years. And we've had great success in a very select population. Those who have, primaries removed, low CEAs, long duration of time on systemic therapy with good control. If you've identified that patient that's really responded well to systemic therapy and has been in control for some time, you can really see, very long-term survival, approaching 10 years for many patients. So really a very important tool in our armamentarium, and we now have some randomized data that we'll be talking about at this meeting, actually, to confirm that.
Right. Yeah, just to add to that, I think the SABR COMET study, which is a phase 2 randomized study, has given us enough information to say that in oligometastatic diseases, local therapies do contribute and improve the overall survival. So I think that that gives us a lot of confidence in using using some form of local therapy in oligometastatic diseases. And to add to that, I'd say if the metastasis is in the liver, I like to use some form of local therapy because liver tends to protect the tumor. Liver is a sanctuary. It protects the tumor from the immune system. It protects the tumor from the chemotherapy. And we know that 70% people will present with liver mets in the metastatic setting. And we know that their prognosis is really bad. So I have very low threshold to use local therapy for oligometastatic liver disease.
Do you have a preferred local therapy that you use?
I would not say preferred is again case by case basis, where I can use surgery, we'll go for surgery. If surgery is not doable, then I'll use something else, thermoablation, SBRT, or one of such modalities.
And what about in cases with patients who have unresectable primary tumors and have oligometastatic disease to the liver? Do you think of those differently? You mentioned potential for conversion to surgical options in the future. How do you think of those patients who upfront are not candidates for their initial tumor to be resected and they only have one oligomet to the liver?
That's a tough one. I fortunately don't come across that too often. Usually the liver is the issue, but yeah, I think that's something, I think radiation can be employed there. I find many times those are rectal or low sigmoid type tumors. Radiation can be very helpful to convert them to be resectable. But otherwise, I think, you're just looking for a response to systemic therapy to really get them there. I try to use triplet chemotherapy there as often as I can if the patient can tolerate it. Often, 4 to 6 cycles of that, you can really convert someone that's unresectable to resectable. And then that really brings, the oligometastatic paradigm into play again, for the liver. Because again, I think that population in particular can really benefit from, complete resection of all sites. Many will recur still at some point, but I still think it has, an overall survival advantage that's often many years, actually.
And how often are you all checking to see if the patient has become eligible for surgery? Are you checking every 8 weeks, every 3 months, every 6 weeks? How often are you checking?
6 to 8 weeks is kind of what we do at our center, to make sure the therapy is effective. If not, then we'll switch on to something else. So 6 to 8 weeks is our standard. How about you, Arvind? What do you
Yeah, completely agree. I mean, I think as you've probably discussed with your fellows and trainees, is like you're evaluating whether a patient is resectable or not with every scan. So especially with liver mets, I think, given the issues with hepatotoxicity with the drugs that we use, as you just mentioned, you want to do it sooner than later, probably within 8 weeks or so before the toxicity set in.
And I would applaud Suneel for bringing up triplet therapy. I think triplet is underutilized, and I think we are seeing a lot of young colorectal cancer patients who can tolerate triplet. And we know from various studies, including tribe studies and all that, triplet therapy improves overall survival, even if they are not resectable, and it increases the conversion rate. And if it is done well with supportive care, I think triplet therapy is not that toxic that most people cannot tolerate it. I mean, we have to select patients carefully, but I really applaud Suneel for bringing that up and highlighting that, we should try to use triplet therapy for these patients.
And you both bring up a really good point, that triplet therapy, especially in the fact that we're seeing so many young patients. I mean, I don't know about all of you, but even since I've been practicing and since my fellowship, I feel like we've seen a dramatic shift to patients who are younger. So other than triplet therapy, are there other methodologies or other things that you're doing different in that population as compared to some of our older patients?
Suneel is our expert. So.
Yeah, I mean, I wish there were more we could do that was unique. I mean, honestly, it's really doing more of what we already do, but employing those more often. I would say, I think that's a setting. Very important to think about the other supportive aspects of oncology care. Fertility preservation, the social needs. These are people who have young families just starting their careers. They need that support. For work, for other purposes. So I think making sure those aspects of their lives are taken care of is so critical. I think that they access care, they continue with care more readily and more continuously if their lives are in good order too. And I think we need to be more involved with that. But unfortunately, as far as I think specific treatments are concerned, there's really no specific paradigm, I would say, for those with young onset disease. It's largely trying to be more aggressive about the things that we have that are available. I do think biomarker testing is particularly important. They're typically left-sided tumors for younger patients. You're going to see more HER2 positive disease on that side. So it's just even more important to do the things you should do anyway, but make sure you're testing both tissue and liquid biopsy for these biomarkers.
And Sunil, fortunately, now MSI testing is universal, so we're screening for Lynch syndrome, but also genetic counseling for these younger
critical
patients.
Absolutely. And thank you for bringing up that profiling, because if there's a young patient, if they don't respond to chemotherapy, but if they have HER2 overexpression, I will use anti-HER2 therapy to shrink that tumor and make them resectable. So this is a group of people where I'm ready to do anything and everything to make them resectable, because I think we have randomized data. The EPOCH trial, although which was conducted 20 years ago, it showed us that systemic therapy plus local therapy, which is surgery, does improve disease-free survival. Now, I understand it didn't show overall survival advantage, but the trial was not powered for OS advantage, to show OS advantage. So based on that data, I think we should try to resect these people if we can.
I absolutely agree. I mean, it's like you were mentioning, these patients have different challenges than somebody who's in their 60s. They have young children. They have other things that we need to take into account. And that goes back to your ABC methodology. It's really important when we think about these patients, how we can be as aggressive as possible while maintaining quality of life, while hopefully prolonging life.